We'll move to the next case, globe trotting, Namrata Mathew from Medicine 3.
Good morning, I'm Namrata. I'm presenting on behalf of Medicine 3. My presentation is titled Globetrotting. So Miss S is a 19-year-old high school graduate from Vellore, and she presented with intermittent fever for 3 months, generalized fatigue for 3 months, unintentional weight loss for 3 months, abdominal pain and loose stools for a month, and bilateral painless lower limb swelling for 2 weeks. Fever was mild to moderate, not associated with chills, and she had abdominal pain that was worse after meals, diffuse and moderate, with a history of passage of multiple loose watery stools every day without blood or mucus in the stool. She had generalized fatigue and poor appetite, and all these symptoms led to her not pursuing a college education after completion of her high school. Menstrual cycles were regular till the onset of her illness, and there was no history of heavy menstrual bleeding. She had no TB contact or prior TB and no major illness. At 3, she was diagnosed and treated for a UTI. She had been admitted in Chennai for a pyrexia of unknown origin, and a CT had been done which showed bilateral tree in blood appearance suggestive of an infection. For some reason, she had decided not to take treatment there and had presented to CMC for further care after transfusion of a unit of blood there. She was born to third-degree consanguineous parents and is the eldest of 3 siblings. The other 2 siblings were twins and they were well, and there is no similar history in the family, and there is no history of GI malignancies or IBD in the family. So on examination, she is emaciated, pulse was 98, blood pressures were 100/60, afebrile and with a respiratory rate of 22. She was pale and had bilateral pitting pill edema. Oral cavity examination revealed oral candidiasis. There was no significant lymphadenopathy, and per-abdominal examination was significant for diffuse tenderness on palpation with shifting dullness. The other systems examination were largely normal. So the clinical syndrome is a 19-year-old woman who's premorbidly well. We have chronic fever. We have a chronic non-inflammatory small bowel type diarrhea, constitutional symptoms with pallor but no lymphadenopathy, and pedal edema and ascites. So differentials are many. Chronic infections are the biggest differential that we have to consider. Tuberculosis, enteric bacteria like Whipple's, parasitic diarrheas, viral diarrheas, and HIV enteropathy. Autoimmune diseases, IBD would be our biggest player. Rarer ones would be malignancy, autoinflammatory syndromes, immunodeficiencies, and other differentials I could think of were amyloidosis, but the fever is not explained, hyperthyroidism, and pancreatic exocrine deficiency with a current episode of pancreatitis. So her basic investigation showed a normocytic anemia, normal counts, normal creatinine, and her stool occult bloods were positive on 2 repeat, stool occult bloods were positive. CRP was elevated, 28.7. So we went ahead with the CT abdomen, which was suggestive of a Crohn's disease with a bilateral, with an intersphincteric abscess, which was confirmed with an MRI, and bilateral symmetrical sacroiliitis. The HRCT only showed a left mild pleural effusion with underlying left posterobasal collapse, but there were no features of lymphadenopathy or active infection. Because she had evidence of IBD, we proceeded with the colonoscopy, and these are images from a colonoscopy which is showing multiple polyposis in the ileum and through the large bowel. So the biopsy of this came out to be mild to moderate chronic ileitis with mild activity in the terminal ileum, mild chronic colitis in the descending colon, and mild moderate proctosigmoiditis with mild CMV infection as well in the proctosigmoid region. There were no necrotizing granulomas that could be identified. So, possibilities could include an IBD or a vasculitis. Her fecal calprotectin was positive. Gastroscopy was done subsequently, which showed esophagitis with ulceration and superficial candidiasis. Autoimmune workup was negative. Bone marrow was normal. Serial blood cultures were negative, and CMV PCR in blood was also elevated. So to add to what we got clinically, this is a lady with chronic fever with constitutional symptoms, probably a malabsorption also, Crohn's with an intersphincteric abscess, probably a prior pneumonia that had been treated outside, esophageal candidiasis, CMV colitis, and bilateral sacroiliitis. So here we'll have to think whether this woman has one issue or she has many issues that are coexisting together. So this is Occam's razor versus Hickham's dictum. To fit all of them into one is difficult, but CMV and IBD we almost certainly have from our investigations. One differential for this is an enteropathy associated T-cell lymphoma. Immunodeficiencies had to be thought of because of the coexistence of candidiasis and CMV with an autoimmune phenomenon, and polyposis syndromes as well. But she had no family history of any GI polyposis. So we went ahead and did immunoglobulin levels, which were normal. CD4 counts were normal, 500. Lymphocyte subset screens were within normal range. And vaccine response screen was negative for measles and varicella. The rest was positive. But since there was still a strong suspicion for a primary immunodeficiency, we did a focused NGS for a primary immunodeficiency disorder, which showed an RIPK1 biallelic mutation. So RIPK1 mutations have been recently described from 2018 to 19, and it has a variety of mutations, variety of clinical phenomena that occur with it. This is the paper from Nature, and this was published in 2022 on the left. This was the first paper that described it in 2019. So what RIPK1 does is it has a role in innate immunity and inflammasome formation in epithelial cells. So a mutation in homozygous mutation in RIPK1 can cause early onset IBD, autoinflammatory disease, combined immunodeficiency, and progressive polyarthritis. So mutations in classically it presents with IBD that occurs at very young age in early childhood, and they often present with perianal fistulas as well. As a subset of this, they can have a CVID as well, which is a heterogeneous primary immunodeficiency disorder, the most common seen in adult population, which occur due to combined B cell as well as T cell deficiencies. So how do we treat IBD caused by RIPK1? You give the normal things, steroids, sulfasalazine, immunosuppression with azoran. Additionally, there have been postulated treatments with RIPK1 kinase inhibitors, and also it has been suggested to target IL-1 and IL-18, but all these therapies are investigational. So learning points are immunodeficiencies can present in adulthood, Occam's razor first, and always consider immunodeficiencies in situations where they appear to be autoimmune phenomena that coexist with infections. Even if the preliminary workup for an immunodeficiency is negative, we should consider an NGS towards diagnosis. Thank you.
Thank you, Namrata. I know you have proven that IBD, there is no question about the diagnosis of IBD. But when you say CMV colitis, what were the evidence to suggest that there is CMV colitis?
She had tissue biopsy proof of CMV.
What did it show? Did it show inclusion bodies?
Inclusion bodies were there in the proctosigmoid biopsy.
There were inclusion bodies. Yes. Okay. And you've done a PCR or
on the blood, which was positive.
Not
on the tissue.
Okay. On the tissue, they would have done immunohistochemistry, no?
Yes, sir. I'm not certain of that report.
Okay. Review that because see the CMV colitis, she has latent CMV infection. When you see CMV copies of less than 10,000 in an immunocompetent individual, may not necessarily mean that there is active disease. That active disease, establishing the disease has to be based on the histopathology, both looking for immunohistochemistry and the IHC positivity for CMV and all that. So that you may have to recheck that. And the other thing is, when you see CMV, even in immunocompromised individuals, let's say somebody who is in their post-transplant setting, CMV copies of less than 10,000 does not, majority of them don't go on to develop disease, either colitis or any of the organ involvement. So usually, as it goes up beyond 10,000, yes, the risk in the appropriate host, it's much higher. Between 5 to 10,000, it could go either way. But in this host, what is likely happening is the latent CMV infection, which is there, with any kind of stress. This obviously IBD flare-up means that there is a significant amount of stress. They have, the latency, they becoming more viremic. So they may reactivate to a certain extent, may or may not go on to develop active disease in the organs. Anyway, but it is interesting. It probably is worthwhile looking at the histopathology a little more carefully.
So if the IHC was positive, we should go ahead and treat.
So you will base your decision for treatment based on whether there is IHC positivity, inclusion bodies, conclusive evidence of tissue disease.
Okay.
Any questions or comments? So how common, what is the proportion? In other words, what's the association of RIPK1 mutation you said? Is it very high association or?
So I couldn't find exactly, definitely there is no, I couldn't find any Indian data. What I found about RIPK1 is they're just, many of them are mouse models to postulate the mechanism of the disease. So I couldn't actually find any prevalences per se. It's not it's not listed also in as a one of the genes that are causative for CVID as yet. And I found one article which was saying all the multiple genes that have so far definitely have been proven to cause CVID, but I couldn't find RIPK1 in that list. But that being said, like most of the disease postulates are from mouse models, and there are very few, like the paper I put up, there were only few papers which actually said what happens in humans. And the first tests were done in 2018-19 only. That's what I could find. I'm not very certain as to what the association is.
Sure. Any questions or comments from people online or faculty? Nobody. Yeah, okay.